Ladies and gentlemen, Gautam, a dear friend and a mentor, is a development finance professional and a SEBI-recognized social auditor with a doctorate in blended financing and an MBA in investment management. He brings nearly 30 years of experience in innovative financing and public financial management. From 2016 to 25, he led innovative financing at USAID, where he designed $300 million plus Samrit blended financing facility. He designed and led USAID 9 million development impact bonds on maternal health and managed about 60 million in healthcare loan portfolio guarantees with banks and financial institutions. Before that, he supported the Government of India on financial planning and budgeting for National Urban Health Mission and helped strengthening major pan-India public-private partnership on emergency response system under National Health Mission. Currently, he co-owns Impact Scale Ventures, where he serves as the Director Innovative Financing. His works span structural blended financing platform, social and development bonds, enabling social enterprises to access the stock exchange, conducting social impact audits, and training the next generation of social financial professionals. Now, the real reason of having Gautam for our podcast. Recently, I think so, as far as healthcare is concerned, financing is one of the most talked about topic. And primarily, the reason behind it is the global changes that we are seeing as far as healthcare financing is concerned, and which has impacted various countries in very different forms. Highly indebted countries, it has got a huge impact, where countries like India, who have got minimal dependency on donor financing, don't have much impact. But it really affects the universal health coverage agenda that is sent by global community. So I am here with Gautam to understand with this expertise, starting with what is the role that health financing plays in universal health coverage. Starting for our audience, just showing that what financing plays as far as universal health coverage is concerned. Gautam.
Well, first of all, thanks, Maulik, for having me here, and also thanks to Accessel to give me this opportunity to share some of these thoughts, kind of a extract of the 3 decades of my exposure with health financing at various levels. So to start with, a very pertinent question, and this is what I had been telling many people. It seems that financing always comes, not always, but many times comes as an afterthought. So you think of a health system design, you think of interventions, you think of everything, and then you do the costing, and that is where the financing comes in. But I would say financing is actually the enabler. It is just like the electricity. You might have an excellent gadget, but without electricity, it is actually of no use. It won't work. So any design, any system, any model that you have, financing is an integral part which makes it work. And therefore, I would say financing has to be thought of not as an afterthought, but more like along the entire pathway of the design, implementation, monitoring. So short answer is financing is the enabler. So whatever we want to do in a UHC, financing will enable that.
So Gautam, now currently what we are seeing in the geopolitical context, the aid has gone down by 22%, right? And you said that it's an enabler to achieve universal health coverage. Now with this aid going down as 22%, do you think that is it realistic that we are going to achieve universal health coverage? Or do we need to change our goalposts to see that what could be achieved through this health financing situation currently available at a global level?
But I would say and along with some of my other colleagues, especially working in the interface of market and the economics of healthcare, we were actually expecting this, and it had to come. There was this time because aid-led healthcare and universal coverage had a reason and had a time around 1970s, 80s, maybe 90s. And after that, as the so-called underdeveloped world started developing and the developed world started stagnating, and that is exactly what is happening right now also, it is very natural to move away from one. Secondly, it is, I would say, something good that has happened because, again, as I said, 70s, 80s, it was necessity. But as we moved on, what aid had actually done, and we all who had been associated with aid-driven healthcare at some point or the other, we would have really seen, because people were almost guaranteed that money is there. So people were not really caring much about the efficiency. So money is there, you just have to spend it. The entire focus is on spending and achieving the targets. So what has happened is, like, I can't really quote the exact number, but like the PEPFAR program that USAID was running, towards the end, before USAID closed out, some of the data that was coming out was actually saying, especially in African countries, less than half of that was actually going to the people. Others was mainly their administrative, consultant, overheads, and all those things. So there was an inflation happening because of the free money available through aid. And this is, of course, not really good, but painful for many countries. But this is a wake up call, just like COVID had been a wake up call, to really look at other alternatives and to look at efficiency of healthcare provisioning while ensuring equity and quality and all those things. So I think this will force all actors in healthcare to look beyond just the point of health service delivery through a public health system to the entire ecosystem, and how we can rationalize and therefore economize on the entire ecosystem and be more efficient.
But Gautam, now let me contradict, because I'm following a kind of health financing discourse at a global level.
Mhm.
If you look at the recommendations right now, it's like the old saying, "Wine in a new bottle, old wine in new bottle." The
Right.
recommendations are still the same, and if the recommendations are are still the same, how are you going to achieve universal health coverage?
See, as a healthcare professional or health financing professional, let's look at what are the recommendations. Increase government spending, increase spending on as proportion of GDP, um, increased coverage so that OOP goes down, so more people comes under some sort of an insurance coverage, greater regulation. Well, these recommendations, as you are rightly saying, had been there for the last 30, 40 years. If that is the case, which is really the case, something is absolutely wrong with people who are saying these things. Maybe we are not really getting it. What is it needed? So what I would say is, the same recommendations continuing since last 30, 40 years is a reflection that things need to be looked at very differently. And aid going down may be one of the indicators that, yes, that is the case. We need to look at things a bit differently, and it's not
So
business as usual.
So what should we look differently, right? Because that's we know we talk about problem statements a lot, right? What is the
Mhm.
solution to it? So government spending, invest in primary care, increase as a percent of GDP. Along with this, what are the newer perspectives that we should be following or taking up to make healthcare financing more available and more efficient?
So I think there is no clear cut set answer that can be given for every context. But what I very strongly feel is, one, we will have to look at financing through a bit nuanced way. So till now we had been talking about, say, healthcare financing. So whether it is percentage of GDP or government spending, it's the healthcare spending that we are talking about, which is very much like talking to people that you need to have food. Now everybody needs different kinds of food at different points of time. So a nuanced approach is needed. One. Secondly, we need to, till now we had been talking about health financing from the health system point of view, but especially in the last 10, 15 years, what I've started realizing is there is an ecosystem beyond the health system. And that is where we, as I was saying or hinting earlier, is the entire market ecosystem, and what drives the market, not always negative or positive, whatever it is, how we can influence that. So let me give maybe a breakdown of it to explain. So for example, if we are looking at healthcare spending, the question is, what do we want this money to be spent on, or for what do we need this money? Now, broadly, if we look at it, we need money to provide services, but that is not an end in itself. Service has to lead to some outcome. So it can be structured as impact financing. We want to achieve impact. Then we need money for infrastructure financing. Then we need money to promote innovations. And right now, people just think that, okay, you give grants, that is innovation financing. It's a little more nuanced. So, impact financing, infrastructure financing, innovation financing, and financing assurance. Assurance is beyond insurance, but on the demand side. So these four kinds of financing needs four different kinds of approaches. It can't be the same approach. You can't say just increase government spending, it will happen. Even with the same spending or maybe less spending, if we are more assured about, say, for example, infrastructure spending, it's not necessary for the government to do the entire spending. Private sector has the money. What they need is a guarantee over a period of time, maybe uh, a period of time where they can achieve the break even. So not a 1 year, 2 year, 5 year contract, but maybe a 30-year lease, 33-year lease, 35-year lease with a hybrid annuity model with viability gap funding. So whatever the infrastructure investment needed, government will not end up spending more than 2 or 5% of that. So it is very much affordable. And still you can have an infrastructure that is maintained. It's like build, operate, transfer mode. So the private sector will come in, they will build the infrastructure, which is a government infrastructure. So government infrastructure built by the private sector, maintained by the private sector, run by the private sector, with all these viability gap funding and all, assures an infrastructure that comes up in well in time, infrastructure that is complete. You don't have cases like you build building but there are no furnitures, no equipment, no people, just a good building just becoming dilapidated. So infrastructure financing very separately. Similarly, when we look for impact financing, government has actually got into, and at many points they will have to provide services. But service provisioning needs management of so many things. You need to have people, you need to have the drugs, you need to have the consumables, you need to have the monitoring, a whole lot of management burden. Now, if you, in a way, uh, out contract this management burden and contract a private party that you have to achieve, say, 100% immunization or 95% immunization by this period of time in this geography, do whatever it takes. Per child immunized, this is what I'm going to pay. Outcome based funding. So whether it is impact bond, whether it is results based funding, even outcome based funding can be a structure which the NHM had tried to adopt to a large extent as a contractual arrangement between center and state transfers, between state and district transfers, and maybe between state and health facility transfers. That you get some basic amount of money, but the other amount of money is based on your performance. So just like we have in the industry performance linked incentive, you can build those structures. So how you put money not on, see, people will do what they are getting paid for. So if you are giving money for salary, people will get the salary. If you're doing money for meetings, people will do the meetings. But if you give money for outcomes, people will achieve that outcome and do whatever it takes to achieve that outcome, because outcome is money. So how do we really look at using or leveraging finance to build infrastructure, to ensure the outcomes are achieved at the quality and price that we want, and the market attunes itself to deliver what we want? Market means basically the market players. Similarly, for innovations is, you just can't give a grant. You have to run maybe a grant challenge. Along with that, obviously some initial grants are given, but then advanced market commitment, maybe some sort of guarantee, or maybe some sort of grant plus investments are needed, because entire money that is needed for investments may not be coming from the government. So how do you leverage? So basically, instead of expenditure budgeting from the government, can we look at leverage budgeting from government? So whatever is needed, government will put in only 5%, 10% of that, but others will put in 90%, because that will produce certain returns. And those returns are either guaranteed through viability gap funding and these kind of things. So we need to look at health financing in a more nuanced way to see how we can involve the ecosystem player. Only then we can assure coverage of the last mile at lower cost through innovations. And that is how we can align the entire ecosystem through incentives, economic incentives that exist in the market, or tweaking those economic incentives. So just talking about regulation, just talking about increasing spending is not going to lead us to USC in any way.
But coming back to what India has been doing, right?
Mhm.
India got Ayushman Bharat infrastructure mission. We have got
Correct.
Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. So do you think that India has started looking at that way in making sure there is more efficiency gains as far as spending is concerned, henceforth achieving universal health coverage? Because in nutshell, what should be our country's approach or India's approach as far as healthcare financing is concerned to achieve universal health coverage?
Well, I would say what India is doing actually the right path. The only thing is it a bit slow, and maybe a whole lot of other learnings need to go. So these are correct way of doing this, whether it is the infrastructure mission, the digital health mission, the Ayushman Bharat and all that. But then, as I said, broadly in health, we need to look at separately infrastructure, impact, innovations, and assurance. So if we take PMJ, it is insurance. So how do we get from insurance to assurance, where a whole lot of OP, a whole lot of drugs consumed as outpatient, a whole lot of wellness care can be covered as an assured package of services? And there is a funding pool, and we can look at how the insurance pool with an assurance pool can be mixed up, but there are innovative ways of looking at it. It needs to be there. Otherwise, right now what is happening is, yes, people are assured of free hospitalization care, but what about the outpatient care? And in some cases there are refusals from the hospital. So why there is a refusal? We it cannot be a police state saying that you cannot refuse. No, if there is refusal happening, there might be an economic reason behind that. Can we tackle that economic reason? Can we give a volume guarantee? Can we give a minimum floor price guarantee for these people? So there are things that needs to enhance the PMJ. Similarly, when we are coming at, say, infrastructure mission still looks at the old way of government spending this entire money through various tenders and doing that. What I was saying is, government need not spend 100%. Government can spend maybe just 5% of that over a period of 20 years, which is feasible. And private sector will be very happy with that, because private sector is assured of 20 years of cash flow, and therefore their cost of capital goes down. So if there is this win-win, why not exploit this? And then if the government builds an infrastructure, it is building only the infrastructure. Whereas if it's a PPP mode, then it is infrastructure plus maintenance plus running of that infrastructure. So build, operate mode that normally happens in whether airports and all that. So those kind of things can be adopted. And that is actually something peculiar, because the same bureaucrats who are when in railways or say civil aviation and infrastructure, they are adopting these models. So we can just tweak it and adopt in the health sector also. So whatever money, say for example, India has put on the infrastructure mission, 1/10 of that money annually can produce better infrastructure and where it is needed. Because obviously, when the private sector comes in, they will come in with a viability thing. So either they do it where it is viable, or where it is not viable, a viability gap funding has to kick in. So that is how you bring in the ecosystem players and then therefore assure UHC.
So, Gautam, going to the analogy that you gave about railways and airport kind of stuff. Now, historically, I mean, I remember in 2011 also there was a public-private partnership policy which
Mhm.
was announced, right? But we did not get a lot of kind of attraction as far as PPP policy, and primarily I think so because there was the guarantee word that said the footfall guarantee was missing out there.
Right.
So, do you think that India currently is ready, and I think so both at a policy level or at a delivery level, where private sector can come in? Because again, in lot of argument that we have been speaking about, the role of private sector is very, very crucial. And at the
Exactly.
moment, we see that there is still a lot of trust gain needs to happen both at public and private sector. So, what should be the immediate steps to take to bringing this trust gap between public and private sector?
See, first of all, because we are talking about UHC can be only achieved with this mix of public and private. It cannot be achieved only by either private or only by public. So that is the bottom line. So if we leave one sector, we are not going to achieve UHC. One. Secondly, how to include the private sector. Now, the moment we talk of private sector, especially in the health context, we start imagining hospitals like, say, Apollo and these things. That is not even 10%, 5%, 6% of the private sector. So when we talk of private sector, there is organized private sector, there is unorganized private sector. I'm not talking about healthcare delivery only. I'll come to the other part later. So just healthcare delivery private sector is organized, unorganized, tertiary, secondary, primary plus secondary, because primary by itself is not a good business proposition. It has to mix primary and secondary. Now, our experience, especially my experience with USAID in last 4 5 years or 6 years, we had been working on projects through this private sector networks, and we actually found if you go to tier 3, tier 4 cities, the mid sector of private sector, basically primary secondary combo of say 10 to 30 bedded hospitals, almost 50% of them, or all the hospitals, 50% is the occupancy rate, and that is viable. So these are basically mostly a couple led or doctor led businesses. The moment their investment is recouped, they are quite happy with that, and they can recoup that within 50 to 60% of bed occupancy. So just imagine across India, across all these networks, 40% of capacity is lying idle, and we are not able to use it. And if you want to use it, we can use it at marginal cost because they have already recovered their investment. It's just the cost of consumables that is needed to be paid to them. So no need to pay the full cost there. So that is one. Secondly, again, when we now talk again of the private sector, the general perception and the lack of trust that you very rightly mentioned is, and which is very real, the sort of fleecing of the patients. Now, if you look at the healthcare, one is the tertiary level healthcare at the hospital level by the private sector, where a particular patient, maybe in 10 years, there will be one visit to that hospital for a particular issue, or maybe 10 years later. So the probability of that patient coming is low, and therefore the hospital has to make all the profit and recover all their cost and incentives in that one go. Obviously, it will be a fleecing. But if you look at the primary healthcare in the private sector, they gain money by building or gaining the trust of the entire family, which means the private primary healthcare focus is to ensure less hospitalization, is to ensure good quality care, is to ensure personalized care over a period of time. So already within the private sector, there are these two separate incentives that we see: an incentive to fleece, and incentive not to fleece, not to hospitalize unnecessarily, but to provide good quality care. Why can't we have a policy where we don't look the private sector as one single entity, but at least these two separate markets, and use the incentive of one market to regulate the other market and not just police them? So one is nuanced approach to the private sector. Secondly, healthcare private sector is just not healthcare provisioning private sector. Government may say that we don't believe in the private sector, but government is not doing the manufacturing of drugs. They are not doing the manufacturing of equipment. There are other insurance companies there. For example, in India, the central government health budget outlay is approximately $10 billion per year. $10 billion per year is the Indian home-based healthcare market that is already existing, just equal to the entire money that the government of India is putting in. So there is an entire market out there. So if we just say, if, again, for example, if we just combine the state and central annual budgets, approximately 40-45 billion. But the Indian healthcare market is 300 billion, growing at 16.7% per year, the fastest growing healthcare market. So if we can't have policies or even an understanding that the entire ecosystem is out there, of which service delivery is one portion, and therefore we need to create good linkages, and good linkages means good incentivized linkages, which takes care of the economics as well as equity. So till we do that, just viewing private sector as okay, either have insurance or just regulate them, well, that is a very, I would say, incomplete understanding of the private sector. And therefore, I will again go back that UHC has to have both, and therefore policy needs to know the nuances of the market and deal with the market accordingly.
And I think so. As we move forward, I think so with governments, a lot of policies where they are opening up and they want private sector participation. I think so. It will take some time in kind of getting this trust and getting public-private working together. But in the
Right.
meantime, I think so. We also have currently humongous amount of money that we are spending already through public health expenditure, right?
Right.
And do you have any recommendation or suggestion on how to enhance efficiency of it, right? Because what we see that whatever we are spending, not quoting any bureaucrat, but whenever we talk about that, there is enough money. First spend, then ask more, right? And
Exactly.
we know there is
Exactly.
a fiscal deficit already at most of the state level where health is a state
Mhm.
subject. So, it's a kind of a quagmire between constrained fiscal space, inefficiency in spending, how we can strengthen that, whatever we are doing. So, in the meantime, we work with private sector. We also need to strengthen what's happening right now. So,
Exactly. Right.
what are your suggestions or recommendations on that?
Well, my very strong, because I have worked almost 20 years with the government and last 10 years with the private sector, having seen both. There are two parts to the question that you asked. One is because of the fiscal constraint. How do we ensure we at least allocate, or that money is available, what is actually needed? Because fiscal constraint is reducing that space. Well, a very clear answer to that is moving away from an expenditure budget to a leverage budget. Use government money not to do, but to unlock, either through guarantees or through some initial seed money, or the government becoming some sort of anchor investor in a larger program, and therefore to leverage. So little government money can leverage at least 10 to 20 times. So therefore, the fiscal space can be solved through that approach. Now coming to the efficiency part, that the money the government has is not spent well. Well, as I said, if you look at the government budget structure, of course, there had been a whole lot of improvement, especially under NHM when it was an off-budget transaction where money was available in a bank and it does not lapse. Of course, you need so that is there, but still there were issues. So one, again, there are two, three issues here. At least the issue of funds flow had been solved to a very large extent by stopping this cash transfer and then starting spending to having the entire money in the RBI. And every unit that spends money is essentially doing an accounting entry with the RBI. So at least the cash flow, cash transfer, that issue has been addressed, and that is a very good step that has been taken. But then there are two other issues. One issue is the expenditure cycle. Now, when I was in NHSRC, the National Health System Resource Center, we did expenditure tracking survey in a few states, and what we understood was that the major chunk of expenditure, especially under this health system strengthening vehicle, the NHM, was civil works, construction, and procurement. Now, expenditure cycle of civil works was approximately 1.5 to 2 years, and the expenditure cycle of procurement 9 months to more than a year. The question is how we can reduce this expenditure cycle, because expenditure cycle, I'm not getting into the planning part. Once the budget is allocated, then what are the steps that we are taking? The authorization, the transfer of money, tendering, execution, certification, payment. So these are the things that goes into what determines the expenditure cycle, how we can reduce that, how we can have a more efficient, maybe online tendering, or payment is currently already online, but at least the online tendering, online authorization, automatic authorization readjustment. So those are some of the things that we need to look at. That is the public financial management thing. It's not a generic. It has to be statewide, state specific, and maybe even sometimes district specific. The other part is how do we ensure that the money that we are spending from the government is producing those outcomes? And there I would very strongly recommend what I just mentioned. We cannot move away from the fact that people will do what you are giving them the money for. If you are giving them the money to do visits, there will be a whole lot of visits. Like, for example, under JSY, we were giving money for deliveries in the institution. That shot up. Did it result into quality improvement? Is a question that we'll need to answer. So put your money on what you want. If we want impact, for example, I said in a particular area, if we want so much of immunization to be happening, or at least 90% immunization coverage, so pay for immunization coverage, not for reaching out, having meetings and all. So people will do whatever it takes to achieve that. If we are paying for, say, not only TB patients completing treatment, but also gaining weight by 6 to 8 kgs. So people will do whatever it takes because the outcome is money. So what we call PLI in the industrial sector might need to be adapted in the government budget flows also, where productivity linked incentives can be for institutions under the RKS and all this. It can also be for people, for ANMs, for doctors, for lab technicians. We can devise performance linked incentives. And therefore, basically what I'm saying is government expenditure moving away from input-based financing to outcome-based financing. And slowly we can get into that.
In JSY also, and in lot many things, demand-side financing also at times creates perverse incentives, right?
True, exactly.
And how do we kind of address that? Because that's one of the biggest challenge as far as demand-side financing is concerned. And I don't know if we have a magic bullet to address that stuff right now.
See, everything cannot be, all money cannot move like that. There has to be some basic minimum. Even if there are no patients, you need to have some basic facility and people and all that. So that is not linked with the outcomes. And please note the word that I'm using. I'm using outcomes and results. I'm not using outputs. JSY has been an output-based payment. So we need to define what we are paying for. If we say how many admissions, we will have short up of admissions. If we say how many, what is the bed occupancy, we will see a change in that. So getting a bit nuanced about what exactly is the payment driver. What is that indicator? It cannot be impact, life saved. because life saved is not one particular intervention, and therefore you cannot pay one intervention based on life saved. There are so many other factors that goes into it. But below that, but not output. So beyond output, below impact, what are these indicators that can start driving? I gave the example, some of this, like the TB. In the TB case, we were actually having, especially in MP, where we tried this out, the pay for result mechanism. In MP, all patients that were completing treatment, less than 20% of them were gaining weight, which means all the 80% of them, 60% were likely to have TB again, and 30% are actually expected to die. So what was the use? But once we got into an outcome-based payment mode, where the outcome payment was based on patient completing treatment and gaining 6 to 8 kg, from 20%, less than 20%, it shot up to 75 to 80%. So it is as simple as that. People will do what you pay them to do. You define what is that. What is that result? Metric.
And Gautam, I think nowadays one of the buzzword is also a big buzzword going around, right? Artificial intelligence, right?
Mhm.
Healthcare financing, lot of this tracking of patient outcome measurement kind of stuff. Do you think that AI has got a role in healthcare financing itself? Because you are better nuanced than I am as far as healthcare financing is concerned. So, what would be your take? Because we see that a lot of efforts are now currently put on AI in healthcare, AI in health financing, and I think there is a webinar also which is kind of announced recently on AI in healthcare financing. So, what is
True.
what? How would you see health financing playing a significant role as well as role of in universal health coverage?
See, I would say, as we began by saying, financing is the enabler for UHC. So little step beyond that. AI would be an enabler for the healthcare financing. What do you need for financing? One, you need to know what is the cost. Second, you need to kind of game or simulate that if I do this, what will happen? If I do this, what will happen? Happen in terms of impact as well as the cost and outcome and all. Whatever I'm trying to do, is it economically viable? How can it be made economically viable? All these are scenario building. Future, we don't have data. We might have data, but that is incomplete. That is exactly where the AI comes in. So it learns from pockets of data. It builds that data into a larger data map, from which it helps into projections, future projections. Basically, yeah, means that is what AI does. Not only learns what has happened, but also it can predict, and that prediction can also be then we can keep on modifying, because there are many interventions happening. So one is prospective, retrospective, but then if we go prospective use also of AI will become more smarter. So we will not need to spend a whole lot of time doing costing exercises, budget tracking exercises, model building exercises. That will happen quite quickly, and the DSS, the decision support system, will become much faster. That okay, if we do this, for example, if you want to do, see, as I said, market is not driven by government orders. Market is driven by incentives. So if I want to change an incentive or insert one such particular law, what is going to happen? AI can tell us that, because again, market is not linear. It is a complex adaptive system, and it's AI which is best suited to tell us the outcome of a complex adaptive system interventions. So I think AI will have a big role to play, especially in our learning, creating scenarios, projecting, and helping in policy decisions, investment decisions, policy decisions. All those.
So Gautam, what I've been hearing in past half an hour is that healthcare financing, right, is an important lever to achieve universal health coverage, right? But we need to move away from the current thought process, or we need to improve our current thought process in making investments based on the outcomes, and investments need to drive outcomes. So it's both way around, and the government expenditure can be kind of managed by having government playing a role of leverage rather than investing a
Exactly.
lot. And obviously, a lot of decision making that requires in healthcare financing could be enabled by artificial intelligence, which can create a large learning models, and which can help in setting up priorities as well as making sure that there is an efficient use of money. If I paraphrase
Completely.
our entire half an hour discussion, would it sum up appropriately?
Exactly. You have summed up quite well. So basically, AI plus financing, a combination of that will help us this nuances, because these nuances were not happening. I won't really blame people, because it needs a whole lot of getting into it, And many people work in certain pockets throughout their life, either in public system or only in pharmacy and that sort of thing. But AI will help us bridge that. And exactly like putting your money on results, using leverage rather than trying to do the entire thing yourself. And everybody leverages itself. Private sector leverages public, public sector leverages private, both leverages the not-for-profit sector, and all three leverages the community. There's a whole lot of community capital available with the community, which is not monetized yet. The traditional knowledge, the networks that they have, the beliefs, which can be both enabler as well as disabler. So how we can use that asset also as a
Uh,
leverage.
Thank you very much, Gautam, for your time. It has been pleasure. And as an Indian, it felt heartfelt to hear from you that India has made kind of inroads in kind of right direction, but it still needs to have a lot to catch up. But
Mhm.
as far as I was told by one of my another friend that as far as the direction of vector is right, we should not be worried about the pace at which it is going. But it has been pleasure talking to you, and thank you very much for giving us time. I think so. This podcast is going to help a lot of people working in health financing to think differently or think in a broader perspective rather than narrowly looking at allocation and expenditure, but looking at how market shaping is equally important to shape healthcare financing and achieving universal health coverage. So once again, thank you very much, Gautam, and it was a pleasure talking.
Thank you. Thanks.